So our last speaker, but not the least, and the hero is Dr. Sri Ganesh, who is the chairman and managing director of a Netradama group of hospitals, a very innovative surgeon with many innovations to his help. And he is going to bring out his genius by talking on cataract post-phakic IOS. On to you.
Thank you, Chitra. Just a minute. I'll just get my presentation up.
Do we take one question with for Sanjay's case?
Okay, no. I'm ready.
Okay.
So good evening, everybody. And I would like to thank Dr. Chitra and ARC for inviting me to this excellent program on phakic IOS, where a lot has been covered and learned. I'll be talking on cataract in post-phakic IOLs. Now there are, if you look at the incidence of cataract in after ICL, the incidence in the V4 was about 1 to 2%, as reported in the FDA study. But with the V4C, with the center flow, the incidence is probably less than 0.2%. It's very low. And especially if you have a good vault, then it is less. The reasons can be because of iatrogenic trauma during the procedure, or a very low vault, which is touching the crystalline lens. And normally you get a anterior subcapsular cataract. You can also get some amount of nuclear sclerosis, because in myopes, some amount of early nuclear sclerosis is expected. And in the other types of phakic IOLs, like the Verisize, you see more of nuclear sclerosis than the anterior subcapsular. In the ICLs, it is typically subcapsular, anterior subcapsular cataract. So I'll just show you 3 cases. Well, if you look at the incidence, I mean, the etiology and incidence in which are the patients who are more prone. IOLs more than 15 diopters are more prone for cataract, age over 45 years, and a low vault, vault less than 100 microns. So I will show you 3 cases of cataract in post-ICL situation and how I manage them. I have no financial interest. This is a case which I did recently. You can see that there is an anterior subcapsular cataract. I make a 2.8 mm incision and a trapezoid incision that helps delivering the ICL easily. I put in viscoelastic, go under the ICL with the viscocalina itself, and then just nudge it into the anterior chamber. Then I use the same holding forceps, grab it in the optic haptic junction, and with a twisting motion, this is very important, slight rotation and a twisting motion, you're able to pull the whole lens out through a 2.8 mm incision. It's better not to extend the incision, otherwise you can have iris prolapse and a leaky wound. So it's better to remove it through the 2.8 mm incision. And then you continue with capsulorhexis. You can see that there was a little spider sign there. That's because the zonules are weaker in these high myopic patients. And once you complete the rhexis, then that's the these soft nucleuses can be prolapsed into the chamber. I'm using a Centurion. I keep the IOP at 20 because I don't want the AC to deepen suddenly, and under topical, it can be quite uncomfortable if you use a high IOP. So there's a 20 IOP, and these cataracts are quite soft. They can be evacuated mainly with just vacuum. You don't have to use much of phaco energy, and surgery itself is quite fast. Pre-op assessment is very important. You will have to look at the macula. Some of them may have myopic degenerations or macular hemorrhage, which can again be a problem post-op if you don't do the assessment properly. You also have to do a specular to look at the endothelial cell count. Here I'm using a single piece, a 3-piece IOL. This is the Acrysof Expand series +1 diopter. Most of these high myopes need a very low IOL power, which are available only in 3-piece lenses. As far as biometry goes, you don't have to use any special nomograms. If you're using optical biometer, I use the IOL Master 700 with the Barrett's formula. This is a second case where I'm using the femto. So when you use the femto, here I'm using the catalyst. After docking, what happens is usually there's an error message because it's not able to identify the surface fits, and it identifies the anterior surface of the phakic IOL as the anterior capsule. So you'll have to do the settings manually. You set the pupil margins, and then even the anterior surface has to be shifted down from the anterior surface of the ICL to the anterior surface of the crystalline lens, the cataract. So this is what I am doing here. If you don't do that, then it will incise the phakic IOL. So once you set it in both meridians and confirm that it is okay, then you can verify all the parameters. Sometimes the pupil is a little small, and then you may have to change the pupil size or use pupil maximized. In this case, once I've done the fitting, this is the most important point here, that manual fitting of the surface, anterior surface of the crystalline lens. And once you have done that, then you can verify all the surfaces and parameters. And here you can see again, because of the pupil size, I've kept a 5.2 mm rexis. I use a pupil maximized to center it, and then I go ahead with firing the laser for the capsulotomy and the nucleotomy. And then I shift the patient to the microscope. I make a side port 1 mm incision and a 2.8 mm incision. This is again a trapezoid incision. So when you make a funnel shaped trapezoid incision where the inner lip is slightly large, about 3 mm, then it's very easy to remove the lens. Then put in viscoelastic under the lens, lift it up gently, and you want to go with your ICL loading forceps, grab the optic haptic junction, and with a twisting motion, you can easily pull the lens out. So the explantation is quite easy. It's very important that you use a forceps to complete the rexis, because sometimes there may be tags, especially post-phakic IOL when you do the capsulotomy. And then here I'm using a visco chop technique where I inject visco into the nucleotomy grooves to separate the soft cataract. So this is a technique which I described and published. And then you can just aspirate the fragments very easily. There is some amount of nucleus sclerosis in the center. So this is something you can expect in myopic patients, especially if they are older. And then, of course, here, again, some people may be concerned about the biometry. If you're using ultrasound, again, no need to make much of alteration, because there's not much of difference. So no need for any adjustments. And with an optical biometer, no adjustments at all. And here we are injecting a single piece IOL into the capsular bag. So managing these cataracts post ICL is quite easy if you know the technique, and the results are quite good. This was a case of phaco with ICL in situ. This patient was a high hyperope, and here we decided to keep the ICL as a piggyback lens. He had 13 diopters of hyperopia, and we used a 21 diopter ICL, and he developed a cataract after 2-3 years. So he required a 45 diopter lens, but then we decided to keep the ICL as a piggyback lens, and with that calculation, we used a 30 diopter lens. So here I go under the ICL, and I'm just using the IA to aspirate the cataract. He had nanophthalmos also, 17 point something axial length. So here the ICL remains in situ. You can go in and remove the cataract and then put in viscoelastic, and then I'm inserting a single piece lens, the 30 diopter lens, into the capsular bag. Settle the IOL into the capsular bag, and after that you can you can just place back the haptics in the sulcus. That's the ICL again, which I'm placing back in under the iris in the sulcus. And this acts like a piggyback IOL. This patient had a very good correction. We also have a formula on how to calculate the IOL power, and it's being published in the American Journal of Ophthalmology case reports. Is accepted for publication. We can discuss more about the biometry if there is time on how to do biometry for such cases. Thank you very much for your attention. Are there any questions?
Yes, wonderful talk. Before I take your question on the biometry of these patients, one other question I would want to ask you. These are patients who have been very happy with the independence of glasses, and after doing a cataract surgery in very high myopes, you may not have the right multifocal IOL at all times if you're looking at the imported segment. So then how do you take care of them? Do you do that monovision?
Yeah, I would do a monovision of about 2 diopters. Make the non-dominant eye about 2 diopters myopic, because 1.5 diopters will not be adequate. So about 2 diopters should give them fairly good intermediate vision. I tell them that you will have fairly good intermediate vision, and then the near vision you may have to use glasses, because they need a much higher plus add, the high myopes, to read. And with this, they are fairly happy, because even if you have like 1.5 diopters myopia, these very high myopes, they are still able to read 612, 618 in that eye, and they're fairly happy. So this is how I plan it for the high myopes.
And of course, the question on biometry with the ICL in the eye, how do you calculate?
See, basically, you will have to see, this was a patient who had 13 diopters of hyperopia. So he had plus 13 diopter spectacle correction, and the maximum hyperopic ICL was 21 diopter. So we implanted a 21 diopter, and he had a residual power of plus 4. In 13 diopters, 4 diopters has been corrected. So we kept, while doing the biometry, we kept the target. So the ICL has corrected 9 diopters of hyperopia. So we kept the target emetropia as plus 9. So while calculating, you put it as plus 9. If you put it to 0, we got a 45 diopter IOL. 45 diopter is not available. You'll have to get it manufactured. So when you put plus 9, it showed an IOL of 30 diopters. And so we implanted the 30 diopter lens, and then he was emetropic with just 3/4 diopter of cylinder. So this is how you go about the calculation. And I have a formula for that also. That's being published in the AJO.
That's good. Very good talk, Sri Ganesh. A lot of learning. And one question to you, Dr. Sanjay. I mean, most of the things got discussed in the course of the webinar. Now, if you have a residual power after a phakic IOL, and the IOL, phakic IOL, and it is rotationally stable, but you have a residual power. So now, would you think of removing the ICL or IPCL, or would you do bioptics for this patient? If the patient,
I think it's not a great idea to go in and change the whole system. If the system is stable, let it be. If the cornea is healthy and can support a little laser, and these numbers are usually very low, then we may just do a surface ablation. It works so well.
Any other question by the expert panel to Dr. Sanjay for one case on pigment dispersion and the other situations? Have you people seen something like a small optic capture when you are doing IPCL placement in a keratoconus patient? Have anybody seen that? How have you all managed those situations?
One question with Dr. Sanjay. Can I?
Yes.
Yeah.
Yeah. Have we done the UVM in this particular case to see the sulcus, if there is anything which is there? Like Dr. Rajesh was also saying that if there is chance of iris cyst or anything like that in the sulcus.
We don't have a UVM.
And because that could be one possibility, or maybe the haptic has rubbing or maybe tilt of ICL or IPCL, whatever it was, which was in one direction. Was the vault uniform all over?
Yeah, it was uniform.
One
Absolutely
question
uniform.
I have, Dr. Sanjay.
Yeah.
Did you do a PI in this case, surgical PI?
No,
Okay.
it
Because
was just a
two
routine
things come to
myopathy.
my mind. One is a cyst which got ruptured. As Dr. Purendra said, me and Dr. Chitra was thinking about that. So UBM could have probably solved the problem. Or
Yeah.
maybe if you did a PI and there's a late leak which got collected there due to viscoelastic. And now since the viscoelastic is gone and slowly probably the pigment release from the PI is coming in. That's what one thing coming to my mind.
And was it only pigment or there was a flare and cells also?
Only pigment, huge amount of pigment. That's it. It was like a pigment burst.
Anaga, you have anything to ask, Anaga?
Yeah, sir, ma'am, I was just thinking excellent learning actually here. Dr. Sri Ganesh sir's video about the cataract and the PHAKIC IOL. I had a case where I think this was an ICL, sir, right? Or IPCL. Yeah. So
You are
I can't
muted.
hear you, you're mute, sir. Yeah.
Unmute yourself.
This was an ICL.
ICL, yeah. So I had a case similar with to this. So it's an IPCL, and there initially I thought because it's thicker and more rigid, maybe I would have to extend the incision. So I did the phaco underneath the IPCL, and then when I was trying to remove it, I thought I would try it before without extending, and it came out very easily through a 2.8 only, even without the internal lip trapezoid thing that you showed.
No,
And the only thing is I used a hand-on-hand technique where I used two tooth forceps, so I very gently removed it. So I don't know whether ICL, if it's thinner, could also come out through a simple 2.8.
Yeah, most of the phakic IOLs would come out through a 2.8. Now, why the trapezoid is because when you have a trapezoid, when you have like a funnel shaped incision, the delivery is much easier. The stress on the cornea is less. So if you go back and look at your video, you will see stressed lines at the edge of the internal lip. And there can be some amount of tearing of the internal lip. So the wound may not be that stable. Plus you have more stress on the cornea. So if you make that slight trapezoid kind of an incision, then it's so much easier to deliver and you don't have stress on the cornea.
Right.
Partha,
One point I'd just like to add to what Sri Ganesh said is, it's a good idea to hold the IPCL or ICL from one corner. The normal tendency would be to pull it from the center part of the flange of the haptic. If you hold from one center, it tends to automatically start folding and becomes a conical thing as it comes out.
See, if you hold the haptic is very thin. So there is a tendency for the haptic to tear when you're pulling it. So the thickest part is at the optic haptic junction, which is the rim of the optic. And that is where you have to catch the lens. And if you catch the lens there, then you can easily twist it and remove it very smoothly without any damage, without any stress.
And one more point would be I would not recommend using a tooth forceps, because especially with the ICL, it tends to bite through and tear the tissue, tear the material. A good idea would be to hold it with a McPherson and then, hand technique, then with a needle holder. But using a tooth forceps would tend to bite through and cheese wire the ICL for sure.
With a McPherson, there's a tendency for it to slip. So the ICL loading forceps is ideal because it's got the ridges. So you get a very nice grip on the ICL and you can very easily remove it. So that is my technique.
I use an IOL cutting forceps. So that means a forceps is there which holds the IOL when you cut it. Those forceps have a very good grip. So just go in the center, hold it and pull it out. It just comes as if there was no effort at all. The grip is very nice.
So before we conclude, Partha, you had a question?
Yeah, not a question, just, Sri Ganesh's talk was very nice. And just for completion's sake, when we used to do the artisan IOLs, artisan phakic IOLs, so a cataract with an artisan phakic IOL, a little different in the technique because the artisan would be 5.5 or a 6.5. So that would have to come out, and it's a rigid IOL. So that would have to come out through a 6.5 incision. So once that incision, it comes out, then you have to suture the incision, go temporarily.
Yeah, I'll just give you my technique because I couldn't show that video because of paucity of time in 8 minutes. And most people are doing ICL, so I thought it's more prudent to show just ICLs because the vericize is, I think most people have stopped. But I still have patients with vericize coming back. They come with nuclear sclerosis. So what I do is I make a temporal clear corneal incision and then do the phaco, do the capsulorhexis phaco under the vericize phakic IOL. And then once I completed the phaco and then close the incision, hydrate the incision, then I go superiorly, make a scleral tunnel and then remove the ICL. That is much better and a smoother surgery. Now, if you make a scleral tunnel, remove the ICL and then try to do phaco, it's very complex because the iris keeps prolapsing, your chamber doesn't maintain, you have more trauma. So the best way to do it is make a clear corneal incision, go under the phakic IOL, do the cataract. That also acts like a protection to the endothelium.
I think
So
what Doctor was trying to hint is that we make a superior sclerocorneal incision, remove the lens and suture it up, and then go through a temporal clear corneal incision and do the phaco. That's how it has worked. And as far as removing the ICL itself is concerned, how it I used to try with the lens holding forceps, but it's somewhat a little too thick. So I also go on to the McPherson's right now. Fill in a little bit of cohesive viscoelastic. Don't bring the entire ICL into the phakic IOL into the anterior chamber, but just nudge one of the foot plates into the anterior chamber and go in with the McPherson's, hold it, and then with the hand over hand technique, remove the entire lens. It seems to come out at least in a more organized manner in my hands that way. I mean, if you have the whole lens in the anterior chamber, earlier I used to try doing that. Then it's a little more difficult to handle the whole situation. If you net just one haptic, and then get hold of that and then bring it out, then it comes out.
When you remove the whole lens in the antechamber and you're trying to hold the lens, then there can be angle damage. So it is not advisable. So the technique I showed, I just nudge the upper haptic and then just hold the optic haptic junction, and it's very smooth, very easy to remove it.
Wonderful. So Partha, before I conclude, I have to, it's not a court martial, I have to give a dig at you. He said there's absolutely nothing left to discuss in phakic IOLs. It's been done over the years, but we did discuss. See, there we are. So it's been, so my concluding remarks, it's been a very educative webinar, I'm sure, for all of us. And it's so, thanks so much to all the expert panel for being there right till the end. Although they kept messaging me, they want to go, but they did stay on. So that was a
Kamal Kapoor's dinner is already ready on the table.
Doesn't matter. So what? We just wanted him there. So it thanks a lot to you all. And of course, thanks to our wonderful speakers who were so crisp and clear and so relevant with what is needed and did not keep going round and round at all. And of course, thanks to my dynamic ARC team and my wonderful co-moderator, Dr. Anagha. Our thanks are always due to Mr. Kripal and his AIOS admin team, Sai, and Manjula from Neurotech, who are always that back end support. Thanks are due to Dr. Anand Sethi and his team, who you must have understood by now how they drive these webinars. And our thanks to Entod, our main sponsors who have always unstintingly supported us. And of course, our attendance has been good, as Anand Sethi has told me, and it is this attendance of these attendees which eggs us as ARC, as a team, to keep coming back week after week with different webinars. And all of you really helped to make it a very successful one. Thank you very much.